you again for coming. This is Managing Strabismus, Basic to Complex Cases. We'll be presenting cases, case scenarios, and we are open to discuss, and you can ask us any questions, hopefully not in the middle of the talk, but anytime later. So we'll just try and discuss and move through the presentations and have a more deeper discussion at the end. So we'll start immediately with Dr. Ankur Sinha, who's going to talk on how to approach esotropia. So it'll be comitant strabismus for a couple, then restrictive and paralytic strabismus, and then finally a VAST where we'll go through the various kind of surgical steps. So welcome everybody.
Thank you, Rohit sir, and thank you AIOS for giving me this opportunity. I'll be talking in brief about how to approach a case of esotropia. So all strabismus approaches, we start with history. So history as in age of onset, the laterality, the intermittent or constancy of the squint, they all tell us about the type of esotropia and the probable issues associated with the esotropia, the birth, neonatal, developmental history, and the associated neurological issues, because then we can have association of a developmental delay, which can have difficulty in managing the strabismus. Check for the head posture, because cross fixation, oblique dysfunction, associated nystagmus can have these head postures along with the esotropias. And also look out for things like ESO-DRS, which are not typical esotropias, and they may have different kind of management than routine esotropias. So do a cover and cover test, always kind of find out whether it's a true or a pseudo esotropia. In this child, we can see that the lateral sclera are more shown as compared to the nasal sclera because of the broad nasal bridge. So this is a pseudo esotropia. And this girl also looks like to have an esotrope. But then once we do the cover and cover test, we can actually see that the eyes are coming in. So this is actually an exophoria and looking like a pseudo esotropia. So it's not a surgery because she came for a surgery for esotropia and she has an exophoria. So you can't operate these patients because they do not have actually, they squint and you do something, they'll land up with diplopia. So ocular movement should be checked. Like this girl, we can clearly see that the left eye is up and inside. So it's an esotropia with significant inferior oblique overactions. In this case, we can see there is one minus abduction of both the eyes. So probably it's not a simple esotropia. Now in this child, we can see the child does have a left esotropia, but when you look carefully, ask the patient to move right and left, you can see that the eye does go up. So it's a case of esotropia with inferior oblique overactions, both eyes. We can see in both the eyes when they go up and above. Refractive error is to be checked. Like this is a small child. Whenever you show a toy to this child, the child has an esotropia, and all what is required is to give him proper glasses even at this age. In this case, we can see that the esotropia is partially corrected from say 30 prism diopters to approximately 15 prism diopters. So it's a case of partially accommodative esotropia. And in this case, there is no effect of glasses. So this is probably an infantile esotropia, and we will have to plan this patient to manage this patient surgically. Whenever we prescribe glasses, always check for the fitting and the usage, because this child is looking over the glasses, and whenever the child is looking over the glasses, the child also has an esotropia. Another case where the glasses are tilted and kind of distorted. So the distorted glasses does not allow the child to be kind of seeing properly. Once you make them right, the child is able to see clearly through the glasses. Fundus and neurological examination is important because this is the case which I showed you before, had a bilateral limitation of lateral movements of both the eyes. So this case has a papilledema, and the cause here is intracranial space occupying lesion. So the 6 nerves can present like an esotropia, and they can have severe life-threatening issues along with it. So esotropias could be comitant or incomitant. The comitant ones can be accommodative and non-accommodative. Accommodative could be a refractive accommodative, non-refractive accommodative, partially accommodative or hypoaccommodative. And non-accommodative can be either infantile esotropia, basic, acute onset, cyclic, or non-accommodative convergence excess. Incomitant can have paralysis, paralytic squints, and restrictive strabismus, and they have to be dealt separately, not like a typical esotropia. Now, infantile esotropia, we approach with a full refraction, whether it's an atropine or a hometropine or cyclopentolate, whatever you want to use, and try and prescribe the full correction, because you want to see how the patient does with the glasses in terms of BCVA and deviation. And then also note the associated movement abnormalities like the DVD, obliques. The child can have Chiantia or the Lang syndrome. And then occlusion or the amblyopia therapy has to be instituted, because some of the esotropes can develop amblyopia, although it is rare to have amblyopia with the infantile esotropia because most of them are cross-fixators. And the management here is surgical. So approach, we have discussed now, how do we plan for a surgery? So counsel the patients that almost all infantile esotropes would need a surgery, and sooner the better. There's a controversy trying to operate little less than 4 months of age, but if you do earlier, they do develop some amount of binocularity and limited stereopsis also. plan symmetrical surgery whenever we're trying to do the surgeries and tackle the obliques also if they are present. And do remember that the small children tend to respond more as compared to adults, so adjust your dosage accordingly. Now, this is another case of infantile esotrope managed surgically. Accommodative esotropia, usual onset is about 1 to 3 years. It may be intermittent to begin with, and the child would be a neurologically normal child. The approach here again would be to do a proper refraction and give full cycloplegic correction. And usually the child gets full correction in case of fully accommodative esotropia. So do assess the vision and deviation with the glasses, and if required, amblyopia therapy may be required. The child is having amblyopia. Now then you can have refractive accommodative esotropias with high AC by A ratio. So these patients would have esotropia because of uncorrected hyperopia, and the near deviation would be more than the distance deviation by a factor of 15 prism diopters. Approach here again would be to do an atropian refraction and give a full cycloplegic correction. I usually begin with giving +3 at the beginning, and then we can try and wean off. The importance here is to give executive bifocals. They actually should be bisecting the pupil, or at least should be the lower border of the pupil. Again, reassess the deviation and the vision with glasses, and if the child has an amblyopia, this has to be treated upon. Now, partially accommodative esotropia, it is characterized by partial correction with glasses. So this is a girl who is having 30 prism diopters without glasses and 15 with glasses. And this is the 9 gazes. We do not have any other abnormalities here. So the child undergoes one medial rectus recession, and the child is absolutely aligned in this case. Now, acute comitant esotropia, it's a sudden onset of esotropia beyond infancy or after infancy. And there's a definite increase in these kind of cases, definitely after the pandemic. And there could be, commonly the 3 types, the Swan, Burian-Franchetti, or the Belchowski's type. And sometimes you do have acute comitant esotropia associated with the intracranial pathologies. So they are to be kind of investigated if you're not filling into the typical group. So approach here would be an atropine and homotropic refraction. Usually doesn't help. Neuroimaging in suspects whenever you have disc edema or any suspicion of having neurological defects, and in the older patients who present with acute comitant esotropia, surgery usually is the answer. This is a 14-year-old boy with the acute comitant esotropia managed surgically. Now, this is another case where we have an older patient who is presenting to you with acute comitant esotropia with gait abnormalities and difficulty in walking. The neuroimaging shows a herniation of cerebellar peduncles into the brain. So to conclude, a proper workup establishing the type of diagnosis of the esotropia, it is a must for a good outcome in these patients. Thank you.
Thank you, Dr. Ankur, for comprehensively covering esotropias. You can just come and join me in the dais. We'll take the next talk on intermittent divergent strabismus, and maybe take a bit of brief discussion on the comitant strabismus post that. Dr. Ankur has very clearly talked about how an esotropia has to be approached. Whenever first time, check for the deviation, check for vision. So manage refraction, ensure an age-appropriate cycloplegic refraction is done so that you eliminate accommodative esotropia. You check for the vision, ensure that if there is amblyopia, that needs to be treated, and according to your diagnosis, you need to manage it. And of course, before that, you have to divide that into comitant and incomitant and manage appropriately. So we'll go on to intermittent divergent squint. Probably increasing, I think, in our population. We're seeing far more divergent than convergent. We were seeing convergence much on a greater amount in children, but now we are seeing a lot more divergent strabismus. Possibly myopization is a factor, but we are definitely seeing a lot more. And actually, intermittent divergent squint is a bigger nightmare, I would say, to manage. Feels simpler, but is actually tougher considering the recurrence. So we'll have Dr. Digvijay tell us about intermittent divergent strabismus.
Thank you, Professor Rohit, for having me as a part of your IC, and it's great to be presenting again in AIOC. So I'm going to talk about intermittent divergent squint, and I think most of the history Dr. Ankur has covered up. It's somewhat similar for this as well. The things in the workup that we have to look at primarily are: what is the refractive error? Is there any anisometropia? Is there a dominant eye? How is the deviation for near and distance? Is there a difference in terms of the near deviation after you do, you give a +3 diopter lens and relax the accommodation, or if you do a patch test? Is there a pattern? Is there any lateral incomitance? How is the fusional control overall? And in terms of stereoacuity, how is the stereoacuity of the child, both up to the stereopsis as well? Because they will often have simultaneous macular perception, BSV, but the stereoacuity is what starts to get affected first. And based on this, you will make a diagnosis. Is it a basic type of intermittent exotropia where the near and distance deviation is similar? Is there a convergence insufficiency type where you're going to get more deviation for near than distance? Is there a divergence excess type where there's more deviation for distance than near? And is it a simulated divergence excess type where, after doing a patch patching for a long time, the tenacious proximal fusion breaks, and then you actually get a same value for near and distance. So based on that, and this becomes important because it changes our management a little bit later down the line. In terms of the therapies that we have, there are two options. You've got non-surgical and surgical. Non-surgical is optical therapy. It is therapy in the form of certain exercises. It is therapy in the form of prisms. And this maintains the sensory status of the eye. But the definitive treatment to correct the angle is actually the surgical therapy. So optical treatment, you want to give the optimal refraction because you want to have the best images in both the eyes so that it fuses the image. And in myopia, we want to give a full correction. You can give a slight over minus as well, though beyond that it causes asthenopia if you do an over minus, which is beyond 0.25 or 0.5. But generally, a optimal correction there. For hypermetropia, give an optical correction, optimal correction. If there is a high AC by A ratio, you could undercorrect slightly. You want to give in presbyopia, you want to give the lowest near plus that you can give, and sometimes you give bifocals in the form of minus segments below or above based on whether it's a convergence insufficiency type or a divergence excess type of exotropia. So these are all, you can play around with the optics. Prisms are used in the interim to help children fuse. These are based in prisms. They can also be used in the form of exercises that there to stimulate the fusion. And these of course are essentially there for smaller angles. You can't correct a very large angle with these prisms because then it affects the quality of vision and it will break up even more. For orthoptic treatment, that is I think very popular in the form of convergence exercises, synoptophore based exercises, and now a lot of computer based exercises that are there. These generally work as supplement, increase the control, but they're not going to change the basic deviation. So they're basically more like a support treatment that you can add along with it. Surgical treatment is where it primarily comes in, and we do a surgery basically to get a good fusional control, to ensure that this binocularity is there, and to correct the angle. And it depends really on the age, the amount of angle, and the squint, the type of squint. Surgery is indicated in cases where either you're going to have a deviation for a large part of the day, there is an effect, it's affecting your binocularity, it's getting worse, the basic deviation, the Newcastle score is high, which is again a sign of how good the control is, or you're getting a secondary convergence insufficiency. So these are the cases when you want to operate. When do you want to operate? Literature is mixed up. There is early surgery, late surgery. Everybody has advocated different things. Generally, I look at it individualized. We try to see if the child can get visually mature. That is better because and if the stereoacuity is maintained. But yes, of course, if one of the indications gets hit, then even at a young age we will operate. And in terms of the choice of surgery, in adults we typically would do a recession resection. Again, that would depend upon, it could be unilateral or bilateral. There are advocates for both. Generally, a unilateral works well. In children, we do a symmetrical bilateral kind of a recession resection, and it would depend also upon what type of exotropia it is. So these are the basic parameters to look for before you decide your surgery. Lateral incompetence is something we should check for because we need to slightly undercorrect our surgical dosage when we are doing that. And options are recessions of the lateral rectors, resections of the medial rectors, or a recession resection, and you could use either, again depending on the type of squint that there is. And unilateral versus bilateral. Unilateral, generally in adults we are using bilateral, in children because it's symmetrical, but you could choose either, and results are almost similar. Success criteria: if you get an optimal correction or even a slight overcorrection is acceptable. You should have binocularity, you should have good fusional control, and these are the kind of primary criteria that you're looking for in terms of the outcome. For undercorrections after surgery, if you could do certain exercises for a small undercorrection. Sometimes you would have to go in and revise or do a second surgery. That's there. You can use prisms in the interim period, and of course, over time, you adjust your surgical dosage also based on how your results are coming. Overcorrections, we do aim for a little bit of overcorrection in adults, not so much in children. But again, overcorrections are dealt with either in the form of initially managing with prisms temporarily. But if there is a large overcorrection and you've developed an esotropia, you will have to go in there and operate again, and you don't want to wait too long in visually immature children. So I'll just show a few cases. So one optical correction is correcting this intermittent exotropia very easily. You can do an R&R procedure in an adult, as you can see here in this adult patient. In children, we do a bilateral surgery or a bilateral recession, but again you could choose, and particularly if there's a pattern or A or V pattern, then you want to combine it with your obliques in both the eyes, so their bilateral surgeries work well. Bilateral lateral rectus recessions, again you can correct the pattern as you see in here. That's the oblique being operated along with the resection procedure. And for small squints, you need to first figure out why is somebody breaking into a small angle squint. There may be some oblique or something else along with it, but you can again get away with a one muscle surgery. And if you get an overcorrection, this does happen. So this was an exotropia in a kid that I saw in IXT. We operated. He landed up with an esotropia, which was a little bit beyond what we wanted. So in the interim, we gave him some prism glasses. And over a period of 1 year, as you can see, he became quite ortho and doesn't need them anymore. So you need to learn how to manage those as well. Thank you.
Thank you, Dr. Digvijay. So we can take any questions or a few points of discussion. At a fault of sounding repetitive, again, refraction we come back to. Refraction is the sheet anchor of any treatment for strabismus, particularly comitant strabismus. We talked about accommodative esotropias in needing age-appropriate cycloplegic refraction to manage and correct for the accommodative esotropia component. For intermittent divergent squints, it is the fusional vergence mechanism that is active. So we are seeing binocularly. And that's why our eyes, which have a tendency of esophoria in young childhood when we are hyperopic, and exophoria as we grow older and the orbits become formed and the eyes actually get an outward drift. So because of that, the fusional vergence is preventing all of us from turning from an exophoric to an exotropic person. So again, the management of intermittent divergent squint becomes increasing and improving first the fusional vergence mechanism, and then subsequently think of how much the patient is breaking, what is the basic angle. Dr. Digvijay pointed out a very, very important fact. In small angle exotropes, please find out why the patient is an exotrope. We know that a lot of us may have an exophoria of almost 25-30 prisms, yet we fuse, yet we are well aligned throughout the day. Then why is a child with good accommodative reserve not being able to fuse, not being able to control 20-25 prisms? And that is because he may have either an inherent fusional mechanism problem, so outcomes may be poorer in those cases, or else again you look for oblique overactions, you look for some reason why the child is breaking intermittently, and that is preventing his stereopsis and binocularity from developing. So we have John Peter Sante from Denmark. Thank you for being here. And yes, you have a comment or question?
Yes, thank you very much for a very nice talk. I really like that.
Thank you.
Do you ever use Botox for convergence insufficiency patients? Have you tried that?
No, I have not used Botox usually for these convergence insufficiencies. Mostly I've kept that either for esotropias, in children, or in terms of paralytic squints. But so far I haven't had. Have you had any?
So no, we also haven't treated acute comitant esotropias with Botox. Although, I mean, we generally operate them for surgery. Although there are a couple of good reports with a lot of data now on the use of Botox in intermittent in acute comitant esotropias.
Yes, so I was looking at CI, convergence insufficiency. And I think the problem with the CI is that it's a problem who it gets back and back to us. We treat them and problem comes back, and we never get rid of these patients. So we don't want to do surgery every time. And some of them will do well, like you say, with the prisms. Some will do well with convergence exercises, but you still have a group where nothing works. How can you help them? You don't want to do surgery every year. So in Copenhagen, we tried to study the Botox in one lateral for CI, and we give them 2.5 units and wait. And usually, many of these patients have been symptomatic for years. They haven't read a book for years. You give them one injection of Botox, and after a week or two, they call me back and say, "Oh, I can read books again. I can read books. I begin studying university again." And the funny thing about Botox for CI, it only works chemical 3 months. We know this. But for this, maybe they come back to a range where they can fuse again. So this actually lasts maybe for 6 months and even 9 months for if you just give one Botox injection to the lateral rectus. So now we looked at, we just published last year a group of treatment refractive patients. So CI patients, nothing worked. Exercises, prisms, and we didn't want to do surgery. So we gave them Botox, And we found that more than 60% were happy, doing well with Botox for one injection. And now we have a cohort of maybe 30, 50 patients coming back every year having Botox, one lateral rectus, and it lasts for not the first time maybe 4 or 6 months, next time maybe 6 months, next time maybe 9 months. So they come back, they call us and say, okay, I can't read again, can I have another Botox? Yeah, sure. So we have every month a Botox clinic. They come in, have a little dose, and go home again. And they read and keep perfectly well.
So what is the mean age of these patients that you have managed for CI?
So, well, all age groups. We also have children down to 12 years of age we treat. But
predominantly must be the older age group where they are kind of breaking for near, or?
I think we have all age groups.
Because children would tend to do fairly okay with exercises, but yeah, with the older patients, yes. It can become a challenge. One, because they anyway presbyopic, so they are not comfortable doing the exercises.
Yeah, and Oberminus doesn't work in elderly either.
Yes. So great, thank you, John. Thank you very much.
Very quick and keep the patients happy.
Yes. Dr. Laila, just we'll have a question and then we'll move on to the next.
From what I understood, you're doing a lot of Botox for these convergence insufficiency. So I would like to know how many of them completely recovered? Fusing? Never. So it has to be repeated.
Yes. So it means often we don't understand why, because when we measure them, the measurements are always the same, but they're happy and they say I can read again, and the measurements are still a little exo, but they're fusing.
Thank you.
I think what we do, what we understand, we weaken the lateral, and we just give them a little push inwards, and they can keep working their muscles back, and then with the shot, we give us a little bit more.
Right.
Thank you.
Alternate the eye when you're injecting the Botox.
We usually give the non-dominant eye. But
Yeah.
I think you can do either.
So I would now, thank you for that, Pearl. And I would now invite Professor Rohit Saxena, the Chief Instructor, to speak on do-in retraction syndrome and a customized approach, something that challenges all of us.
Thank you, AIOS, for giving us the opportunity. Those of you who were there in the Ped-Ophthalm day yesterday would have a sense of deja vu, because it's the same talk I gave yesterday. But yeah, Duans is something that we are still learning. So hearing it again, or me speaking it again, will give fresh thoughts and fresh ideas as we go along. So a quick understanding of pathophysiology. It's an extremely interesting strabismus. Now we've kind of clubbed this and these type of strabismus into a very nice composite name called just CCDDs, which actually translates into a very difficult name, but means that we really are not sure what we are talking about. So congenital cranial disinnervation syndromes, essentially saying that at birth they had abnormal innervations, and that is the manifestation of that we are seeing. So a part of this is Duans, the most common kind of a disinnervation syndrome. And essentially what is happening in this is that initially there is subnormal development or subnormal innervation to the lateral rectus from the 6th nerve nucleus. Because of that, some fibers of the 3rd nerve, particularly the medial rectus subnucleus, go and innervate the lateral rectus. This causes an abnormal action of the lateral rectus when it was actually supposed to be absolutely passive, and there should have been no contraction. It should have relaxed. So because of that, we see a lot of features related to the abnormal co-contraction that we are seeing. Besides the abnormality in the lateral rectus, the other important thing is that the medial rectus is now getting less than normal innervation. So it's a kind of paralyzed muscle. Although we are seeing esotropias in them, we are seeing a tight medial rectus in them. The reason why it is again a tight medial rectus with a tight force duction test is actually because some of the myofibrils that were there in the medial rectus were not innervated. These myofibrils then degenerate to become fibrotic tissue, and that contracts, causing the tight FTT, particularly seen in esotropic Duans. And then, of course, there is a whole lot of secondary muscle changes. So you have a relatively similar pathophysiology, but a huge variable presentation we'll see. And that requires a unique approach to manage every case of Duans. The aim can be to reduce the deviation in primary position, to manage or reduce the abnormal head posture the patient may have, to maintain binocularity, disfiguring retraction, and upshoots and downshoots. We'll just run through a couple of cases and try and see how we can have a kind of customized approach to every case of Duans. This was a young girl with an left eye esotropic Duans, good stereopsis, again something we see in Duans, because the angle of deviation is moderate. It's not a very high deviation, so the patient is able to find a head posture that permits binocularity. So they would have a head posture, have fairly good binocularity, but when they look straight, they're going to have the esotropia manifest, and the head posture often is a little more than the primary gaze deviation you are seeing. So this is a classic case of a typical case of an esodwans. Now, when you come across an esodwans, your management options would be depending upon 1, the angle of deviation, and 2, are there any co-contractions or abnormal retractions that we are seeing because of the abnormal innervation to the lateral rectus? A small angle esotropia with no co-contractions, you can plan with a small medial rectus recession. A larger deviation, you would have to do a greater amount. But the rule goes that do as little medial rectus recession as possible, and we'll just discuss why. So you may have to get a transposition procedure to augment that small medial rectus recession to improve the outcome. And of course, if there is a co-contraction, you will have to add a lateral rectus recession to improve or to reduce the co-contractions. And of course, bilateral, you may have to do that surgery in both the eyes. So in this patient, we did a small medial rectus recession. You can see she was aligned in primary gaze. However, you can see the adduction deficit that is there. So we started off by saying that the medial rectus is actually weaker, and that's what you're seeing in this patient. You're seeing the adduction deficit that is there. This much amount of recession, if you had done an concomitant strabismus, would not have resulted in any adduction deficit. So be very careful in the amounts of medial rectus recessions you're doing. So do not do large medial rectus recessions in the same eye. Always remember, if there is co-contractions, you may have to do differential recessions, recess both the medial rectus and the lateral rectus. Otherwise, you may have something like a simultaneous abduction or a synergistic divergence, because the lateral rectus starts now contracting on attempted adduction against a further weakened medial rectus. It was already too weak to start with, and you have now further weakened the medial rectus. So essentially titrate the medial rectus recession based on the forced duction test. A child with a much larger esodwans, you can see the deviation is much more. In this patient, we did a very small amount of medial rectus recession, essentially to free the FTT, and did a superior rectus transposition. You can see the increase in the abduction that the patient has got. So transposition procedures can help to increase some amount of the abduction that is not existing in the preoperative period. Advantages of transposition, it gives greater abduction versus MR recession alone. The more important thing is that you can do a lesser amount of medial rectus recession for that correction of that deviation. And of course, do not do SRT or a vertical rectus transposition if there is co-contraction, because it's going to worsen the co-contraction. So you can do SRT or VRTs, again depending on what you prefer. Because we already almost always tackle the medial rectus, you can only transpose one muscle. So one muscle transposition, conventionally SRT, but now even inferior rectus transpositions have been reported. LR resections in esodwans up till now were an absolute no-no, and I would still say that I personally have never tried it, but it has been mentioned. You can do a very, very small amount of resections to correct small residual esotropes, provided they don't have any retraction. Otherwise, it will become significantly worse in the post-op period. Bilateral esodwans, you may have to do the similar surgery in both the eyes. You can stage it or do it in the same go at the same time. As we mentioned about, there could be esodwans with retraction. So in this case, you can see not only is there a small esodwans, there is severe co-contraction and retraction present. In this patient, we had to recess both the medial rectus and the lateral rectus. So again, medial rectus recession did bring about a little adduction deficit, but at least we were able to manage the retraction that was there and the head posture by weakening both the horizontal recti. Exodwans actually is a more severe form of Duans, because the lateral rectus not only is abnormally innervated, but has also gone into some amount of contracture. And usually these are patients who will have a lot more co-contraction seen. So you will see, like in this patient, you can, on attempted adduction, the eye has completely gone up into the upper lid. And that's the severity of co-contraction. In this patient, so we'll just generally discuss if you have normal lateral rectus activity. Essentially, there is no retraction or shoots. You can just recess the lateral rectus to correct for the exotropia. If there is associated retraction of shoots, not only you may have to do a little greater amount of recession, for the for the upshoots or downshoots, you may have to Y split it to stabilize the globe. If there is subnormal lateral rectus activity, but there are no retraction or shoots, you may still get away with lateral rectus retraction. But if there are severe lateral rectus, there is severe co-contractions and severe retractions or shoots, you may have to do a periosteal fixation. In this patient, we had to do a lateral rectus periosteal fixation to correct for the angle of deviation and for the severe co-contraction. You can see the result was very good. This was another patient in which we had done the right lateral rectus periosteal fixation along with a vertical rectus transposition to prevent a consecutive esotropia. So if you do a complete lateral rectus suturing to the periosteum, you have completely eliminated the function of the lateral rectus. A third of them we have seen go into esotropia. Now, of course, it's no hard fast rule, but if you have some amount of lateral rectus function in the preoperative period, there is a greater chance that these patients will go for esotropia because this was balancing in the initial period. So, if there is some lateral rectus function and you have to do a periosteal fixation, do a muscle transposition also to prevent esotropia. So, look for abduction. If present, add a vertical rectus transposition. Sometimes the co-contraction retraction can be so severe that there can be hypertropia even in primary position. Do not always think that it is because of a vertical rectus contracture or vertical rectus abnormal innervation. Correct first the horizontal rectus retraction or the co-contraction by recessing the lateral rectus, and then check. Often that vertical deviation may get corrected, or else the SR may be actually tight because of long-standing hypertropia and may have to be recessed very mildly. Orthoduans, remember, it's very, very important to understand that they more likely are not going to need surgery. So unless there are retractions and shoots, in which case you will have to do recessions of both the lateral rectus and the medial rectus. Otherwise, an orthoduans do not intervene because you are more likely to end up with a more an unhappy patient than otherwise. So essentially, indications for surgery are there. Choose your patients. Inform that normal ductions and versions cannot be achieved. Your outcome is essentially primary gaze alignment and increasing the area of binocular single vision, reduction in the shoots and retractions, which often may remain and may not get completely eliminated. Thank you very much for the opportunity.
Thank you, sir. Any questions? Meanwhile, we'll go on to the next talk on third nerve palsy, case-based approach by Dr. Anand Sethi. So, sir, what are the situations where you would decide not to touch a case of Duane's in terms of surgically?
So, not only Duane's, I think we should remember a dictum that if you are not sure that you can make a patient better by your intervention, do not touch that patient. In Duane's, in paralytic strabismus that we are going to see, this likelihood is more. So particularly Duane's, because the patient is a binocularly fusing patient most of the time, and he's come for a cosmetic correction. Remember, you do not want to worsen the patient. So it's very important to choose. So a patient who has who's an orthoduans or has a very, very small angle. Many of these patients come for noticing when they notice the abduction deficit. Remember to tell them that is not going to be improved. If that is their primary goal, do not operate such a patient. He will always be unhappy. So I think we'll go on to the third nerve palsies. Again, another very, very challenging condition. Dr. Anand Sethi, please.
Thank you, sir. Good evening, everyone. I'll be discussing surgical management of the third nerve palsy. So third cranial nerve supplies all the extraocular muscles except the lateral rectus and the superior oblique. It also supplies the levator palpebrae superioris, the sphincter pupillae and the ciliary muscle. The lesion in this case can be at any level, nuclear, fascicular or orbital, and all of these cases will present differently. There may be the palsy may be partial or complete, and there may be associated neurological deficits. So the clinical picture may be highly variable. There can be varying degrees of exotropia, hypotropia, hypertropia and ptosis. There may be aberrant regeneration and varying degrees of contracture of the recti. So it is important to establish a complete ocular motor diagnosis, and we need to examine, look for deficits of the 4th cranial nerve, the 6th cranial nerve, and the 5th cranial nerve. Investigate for the cause of palsy, and allow 6 to 9 months for natural recovery of the patient, natural recovery of the palsy before planning a surgical correction. So what are our options for surgical management? We can perform a recess resect procedure. We can perform medial transposition of the lateral rectus. We can perform periosteal fixation procedures like the lateral rectus periosteal fixation or the medial globe anchor. So to establish a surgical plan, we need to pay attention to certain aspects, like what is the kind of deviation in primary position, what are the limitations of movement, what is the severity of limitation. It is always important to perform a force duction test to identify the contracture of any of the recti muscles. And if there is contracture, it is important to establish if there is any residual function in the involved muscle, and also if there is any aberrant regeneration. So coming to the first case, this is a case of right eye partial third nerve palsy. There is a 40 prism diopters of exotropia in primary position, but the patient is able to adduct the eye up to the midline. So in this case, we can get away with a supramaximal recess resect procedure in the right eye, and we can achieve a good alignment. So what if the patient is not able to adduct the eye up to the midline or beyond the midline? In this case, if the lateral rectus is free, we can perform a lateral rectus to medial rectus transposition, and one of its variants is the full width lateral rectus to medial rectus transposition. In this, it is indicated especially in those cases where there is associated vertical deviation as well. It can correct up to 50 to 60 prism diopters of exotropia when combined with the posterior fixation suture. So here is a case of right eye post-traumatic third nerve palsy with exotropia and hypertropia. So in this case, we chose to perform a full width lateral rectus to medial rectus transposition via the inferior route to correct the hypertropia. Here is a similar case of a right eye third nerve palsy with associated hypertropia, and in this case the full width lateral rectus to medial rectus procedure was performed via superior route. So we can also perform the medial transposition of split lateral rectus muscle. In this case, a Y split is performed on the lateral rectus, and the two slips are transposed to the insertion of the medial rectus. This was described by Gokigate et al., and in the original paper they were able to achieve a correction of 55 to 60 prism diopters of exotropia, but it was prone to undercorrection. So SAXENA et al., Professor SAXENA augmented it with a posterior fixation suture, and a correction of 75 to 80 prism diopters could be achieved. So here is a case of left eye congenital third nerve palsy with a free lateral where the FDT for adduction is free. In this case, we can perform a split lateral rectus to medial rectus transposition with a posterior fixation suture, and we can achieve a satisfactory outcome. So all these procedures were fixed procedures, and to make them adjustable, Shah et al. Inserted the slips of the lateral rectus on adjustable sutures, and this provided the option of adjustability in the post-op period. They inserted the slips of the muscle on the same vertical side of the medial rectus, and it made the procedure adjustable, but in cases of undercorrection, there was not much opportunity for advancement of the muscle. So it was augmented by inserting the lateral rectus in a crossed manner such that the inferior slip of the muscle was inserted at the superior border of the medial rectus and vice versa. Then this enhanced the exotropia correction as well as provided more room for advancement of the slips of the muscle in cases of undercorrection. So this is a case of exotropia due to third nerve palsy, in which and has adjustable nasal transposition of split lateral rectus muscle was performed. In this case, we had an undercorrection of 14 prism diopters in the post-op period, and both the slips of the lateral rectus were advanced to achieve a final outcome of 6 prism diopters of exotropia. So this procedure provides adjustability for the vertical deviation as well, in which case we can advance or recess individual slips to align the vertical, to correct the vertical deviation. So what if the lateral rectus is tight and we are not able to transpose it to the medial side? In these cases, if we attempt a transposition procedure, it can lead to avulsion of the muscle, or sometimes even if we are able to transpose it, it can compress the vortex veins and cause a choroidal effusion in the post-op period. So in these cases, it is important to perform a periosteal fixation of the lateral rectus. This frees the globe for adduction. So here is a case of right eye complete third nerve palsy, in which a lateral rectus periosteal fixation was performed with a medial rectus resection of 8 millimeters, and good alignment was achieved in the post-op period. But if there is no force in the medial rectus, resection will not be able to help. So in this case of right eye complete third nerve palsy, a lateral rectus periosteal fixation was done along with a medial rectus resection. But due to no force in the medial rectus, we had a residual exotropia in the post-op period. So in these cases, we can fix the globe to the medial orbital wall, and we come to the next procedure, that is the anchoring of the globe to the medial orbital wall. So in this case of left eye complete third nerve palsy, the lateral rectus was tight, and there was no force in the medial rectus as is seen on AFGT. So in this case, we performed a medial globe anchor along with the lateral rectus recession of 12 millimeters. So we can see that we have achieved good alignment in the primary position, but it is important to tell the patient that the eye almost becomes still and it will not have any movement at all after the surgery. So here is another case of right eye congenital third nerve palsy, which was corrected with a lateral rectus recession of 12 millimeters with the medial wall periosteal anchor, and with the crutch classes, the alignment is achieved. Coming to the cases of aberrant regeneration may follow acute traumatic or compressive third nerve palsies. So here is a case of left eye third nerve palsy with exotropia and hypotropia. We can see that as the left eye adducts, the ptosis improves. So we see that there is a medial rectus to LPS aberrant regeneration. In these cases, we can plan a supramaximal recess resect procedure in the other eye. The supramaximal lateral rectus recession of the other eye increases the innervation to the medial rectus of the involved eye, and this in turn increases the innervation to the levator palpebrae superioris, and the ptosis improves. Here is another case of left eye congenital third nerve palsy with aberrant regeneration. In this case as well, we see that as the eye adducts, the ptosis improves, and in this case we can utilize this to correct the ptosis. So in this case, we performed a right eye lateral rectus resection of 15 millimeters with medial rectus resection of 8 millimeters, and we achieved a beautiful outcome. Coming to the last section, targeted strabismus surgery. This is indicated for congenital cranial dysinnervational disorders, including the involving the oculomotor nerve, that is the synergistic innervational downshoot and the synergistic divergence. So synergistic divergence, in this case, we can see that synergistic divergence is seen in both eyes. As the patient attempts a dextro gaze, we can see that the left lateral rectus cross-sectional thickness is increasing, that is, it is indicating that it is contracting. And in attempted levo gaze, we can see that the right lateral rectus and inferior rectus are contracting. So the patient is having a downshoot in attempted levo gaze. So in this case, in these cases, the principle is to identify the misinnervation and to transpose the misdirected muscle to the correct site. So a periosteal anchor of the lateral rectus was performed in both the eyes, along with the right eye inferior rectus to medial rectus transposition with the posterior fixation suture. And we can see that in post-op period, the innervational downshoot has reduced quite a bit, and also exotropia has reduced. So to summarize, in the cases of third nerve palsies, it is important to identify the kind of deviation that we are planning to correct. If there is good adduction, consider a recess resect procedure. If the adduction is poor and FDT is free, we can plan a transposition procedure. And if there is poor MR action and FDT is tight, we can plan periosteal procedures. So thank you. What I have not discussed is individual medial rectus palsies, IO palsies, and in those cases a tailored approach is needed. Thank you.
Thank you, Dr. Anand. And I'll now call upon Dr. Rebecca from
Rebecca
RP Center to speak upon 6 nerve palsy. And while you set up, Dr. Rohit, you could tell us a little bit about trochlear palsy.
There's a question. Yes, please.
Sir, all these procedures look so heroic, but how do we counsel the patient for the double vision they'll have even post-op? Because most of these procedures also cause restriction of movements.
So in all these procedures, if the patient has binocular vision, there is the risk of post-op diplopia. Although if you've brought the deviation to fairly close to each other, if the alignment is fairly good and there is very small angle in primary position, they are not going to have a diplopia in primary position, which is what we can offer them. Usually they would maintain a small head posture and be able to be functionally positive, and whenever they look on the side, usually the movement is so much more that the image again starts getting ignored like they were ignoring in the early period. But yes, it's a problem that you have to inform the patient about. And over time, usually patients do. In the early post-op, they may feel uncomfortable, and I've had a couple of patients tell me actually that, you've made me worse than before, and reverse it. But usually a little later, they're usually happy and comfortable, and that's yes, John. I think one
role of adjustables in them, sir.
So some of them you can do adjustables, like we've talked about the LR to MR as an adjustable procedure. If you are going to do any resection, suppose you do periosteal fixation of the lateral rectus, the medial rectus resections can be adjustable, but there is modest, because many of these surgeries, as you said, fairly severe. So the scope of adjustment is only a very small amount that you can possibly manage. Yes, John, and then we'll go on to the next talk.
Yeah, just a short comment. We have the same problem with our patients after the third surgery, and they will, if we're lucky, they will not have double in primary, but they will have double everywhere else. So we give them a occlusive contact lens in the palsy eye, and then they look normal, but they will only use one eye.
So yeah, that's a okay, Rebecca. So we go on to the 6 nerve palsies, and then maybe if there's any more discussion, and then we'll go on to the vast. Yes, Rebecca.
Thank you, sir. Very good evening, everyone. So before I start, I would just say that I have a really bad throat. So maybe I went a little overboard, cheering up for the Javed Ali show yesterday night. So just bear with me. So abducens nerve palsy. So just brushing up the basics, the 6 nerve palsy, I guess, is the most common acquired oculomotor palsy that you will see in your clinics. So there's a very simple textbook diagram which all the PGs they know about, but this you must know. This gives you an idea about the localization. You can localize the exact where exactly the pathology is. So if you look at this, just quickly brushing this up, that the nucleus is present at the level of the pons. It's present in association with very important structures. So you have the 7th nerve, the PPRF, which is the horizontal gaze center, the pyramidal tract. So based on this, you will know that if there's a nuclear or a fascicular involvement, it cannot be isolated. So look for those neurological signs, like a gaze palsy, a 7th nerve dysfunction, a hemiparesis, along with the 6th nerve palsy. So giving you an example, this is a beautiful video. This young female patient comes to us with a problem of movement in the horizontal gazes. So as you can see, there is a bilateral gaze palsy, horizontal gaze palsy. The vertical gazes are intact. The convergence was also relatively intact, but on dolls, the abduction was affected. You also see a facial nerve involvement. As you can see on the photographs, there is a lag of thalamus, the drooping of the corner of the mouth. So this was a case of a horizontal gaze palsy, 6th nerve palsy, and a 7th nerve palsy. So where do you localize the lesion? It has to be in the pons. You get a neuroimaging, order the neuroimaging accordingly, and we found this pons angioma. Now, the 6th nerve could be associated with certain syndromes like Mobius syndrome, where again you have multiple cranial nerve involvements. The neuroimaging usually shows a hypoplasia, so be aware of that. Then this is another patient, young patient, presents to us with a bilateral 6th nerve palsy. But along with this, he also has complaints of blurring of vision and severe headache. Now, fundus exam is a very important aspect in case of a 6th nerve palsy. So we did that. The patient has a bilateral disc edema, immediately ordered a neuroimaging. So this patient has a prominent optic nerve sheaths, partially empty sella, and CSF manometry revealed a raised intracranial pressures. So this is a case of IIH. Now, raised intracranial pressures, either related to intracranial space occupying lesions or maybe IIH, can cause 6th nerve palsy, and that's a false localizing sign. So remember, do a fundus exam in case of acute 6th nerve palsies. And why does it happen? The compression is happening somewhere here, you know, where the 6th nerve is entering the Dorello's canal. So because of this acute angulation in the subarachnoid space, it just gets compressed. Then if it's a cavernous involvement, again, it will not be isolated. You will have 3rd, 4th, 5th nerve involvement. If it's orbital, look for orbital signs like a chemosis or a proptosis. Like this child comes to us with a right-sided 6th nerve palsy. But what you also notice is a proptosis. So we did a neuroimaging, and you see this beautiful cyst lying over here. So it was a case of myocysticercosis. And this was also shown on ultrasound. And this, because the management totally changes. You need to identify what's the underlying cause. Now here the patient was treated with anthelminthics, and at 6 months post-op, 7 months, she's doing pretty well. So whenever a case of any acute palsy comes to you, you must first identify what's the underlying cause and treat that cause or refer the patient for the same. Meanwhile, what do you have to do? You have to give conservative measures to alleviate the diplopia. So patching, prisms, and botulinum toxin. So I guess acute 6th nerve palsy is an ideal indication where you give the botulinum toxin. So this is the botulinum toxin that we use at a center. This is pharmacological. This is actually prepared at a center by the ocular pharmacology department. And we just load it in the tuberculin syringe and give it to the patient. So it has a very dual purpose. One is that it elevates the diplopia, at least in the primary gaze. And second is that it prevents the antagonist, which is the medial rectus, from going into the contracture while we are waiting for the 6th nerve to recover. So this is one example of a Botox patient pre and post. So the patient is, of course, it works very well. The patient usually happy, except from the extremes of gazes, that is an abduction, might have a little diplopia, but most of the cases they are doing well. And complications are very minimal. You see a little subconch hemorrhage, maybe a mild ptosis, and that's usually reversible. Now, if the 6th nerve palsy does not recover at 6 or 9 months, it is then that you have to consider surgical management. Now, what surgery? It will depend on a lot of factors. Now, let's have a look at this case. This is a young patient, has a 6th nerve palsy. So, not much of a ESO, and look at the LR action. That's pretty good. So, a good LR action. In such a case, MR not very tight, you can do a recess resect or a recess plication procedure. But remember, unlike comitant strabismus, you might have to plan a little more. So supramaximal recessions along with plications. Another case, patient has a large angle ESO, marked limitation of abduction. Now on FDT, the medial rectus was found to be tight. Now in this case, whenever there's a tightness in the antagonist, first release the tightness. So we did the medial rectus recession, but that was not enough because the patient has a large angle ESO. You need to augment it with a transposition procedure. So we did the partial vertical rectus transposition. This is the pre and post. And as you can see, not only the good alignment is achieved, the abduction also improves considerably. So that is how the transposition helps, as Dr. Rohit was discussing in DRS. Now, partial VRTs we were earlier doing, but now we have, shifted to SRTs, which is single tendon transpositions. And here again, similar case, marked limitation of abduction. And the patient, you see, is not only well aligned with MR recession and SRT, good alignment, but also the abduction tends to improve. So SRTs also give very good results, just like partial tendon VRTs. So the goal or the aim of surgery in paralytic strabismus would be to eliminate the diplopia in maximum gazes and to achieve a binocular single vision, at least in the primary gaze for the patient. So this is the algorithm for the management of 6th-nerve palsy. So 3 important factors that you must consider is how much is the duction beyond the midline, that how much is the eye going beyond the midline. So this gives you an idea what is the LR action. Second, if the MR is tight on FTT. If it is, you will have to do a MR recession. And if whether LR action is there on active force generation test. So if LR action is present, you can do a recess resect procedure. If there is MR tightness, you will have to do MR recession. And if LR has minimal or no action, you will need to augment or you'll have to do a transposition procedure to improve your abductions. Now, what are the types of transposition procedures? Well, vertical rectus transposition, it could be either double tendon or single tendon. Now, single tendon could be superior rectus or inferior rectus transposition, and double tendon could be full or partial tendon. And all of these transposition procedures could be augmented by either a MR recession, Foster's, or Botox. So these are the various types of, just a diagrammatic representation of these various types of procedures: a full tendon VRT, a Foster's modification, Jensels, Hamilton's, Nishida's. Now Nishida is a very interesting procedure because here you are just splitting the 2 vertical recti and transposing them laterally without disinserting. So there is less risk of anterior segment ischemia. Now, in the single tendon VRTs, superior rectus transposition is more commonly advocated, and this also carries less risk of anterior segment ischemia because you are not touching both the vertical recti. But since it's creating an imbalance in the vertical forces, there is a theoretical risk of inducing vertical and torsional diplopia. Now, we did this study, and we found that none of our patients actually had any diplopia, torsional or vertical. And somehow it tends to balance out. And what we also noted is that in long term, the effect tends to improve. So if there is a mild undercorrection in the immediate postoperative period following SRT, that you can expect it to improve over time. There are very rare case reports of certain torsional and vertical diplopia. And less commonly advocated is the inferior rectus transposition that has been done only in particular or very specific cases like patients of LR palsy with hypertropia, encyclotropia, or a V-isotropia. So giving such an example, this case recently presented was a young boy. As you can see, there is a 6th-nerve palsy. But also what you see is a bilateral SO palsies, marked excyclotorsion on the fundus, and there is a V pattern. So we had to deal with the inferior obliques. We had to recess inferior obliques, so we could not risk doing another elevator. So that's why here in this we thought of doing an inferior rectus transposition along with bilateral IO recessions. And this is the post-op result of the patient, which is pretty acceptable and very good results. So because we were a little earlier, hesitant about doing IRTs, but I think you must choose your cases wisely, and it may have certain specific indications. So we published this systematic review about the vertical rectus transposition procedures for lateral rectus palsy, and we found that quite interestingly, the full tendon VRTs, the partial tendon double VRTs and single tendon VRTs are more effective than full tendon VRTs. So I think that's all about the 6th-nerve palsy. Thank you.
Thank you, Dr.
Yes.
Rebecca. If there are any questions, we can hold them for the end. I'll now invite
Any comments on
comments
this
on
before we just go on to the video-based strabismus surgery? So great.
So I now invite
Looks like
Professor Rohit
the
for
very tough
last.
parts of strabismus were cakewalk for our audience. So I'll just go through. So this is a vast. You can in the middle also interrupt and ask questions. So this will just run through videos quickly, not too much theory. Essentially, a lot of people discuss limbal or phonics. I don't think there is any difference long term in the outcome or your deviation corrections. But yeah, intraoperatively you can face a little bit of a struggle if you're a beginner for phonics incisions, but it's definitely more comfortable for the patient. There are no sutures that are visible, and although it's technically difficult and tough for beginners, and has a little less exposure. I've had sometimes being called for intraoperatively with a fellow who looks like the muscle is coming in a very abnormal fashion, and then you realize they've hooked the wrong muscle because they were going through the fornix. So just be careful. That's it. So we'll talk about weakening procedures. We know that recti recessions are the most common weakening procedures that we do, and there are limits for weakening procedures. You don't want to recess more than a particular amount for that muscle, because that's going to put it beyond the arc of contact and cause severe underaction of the muscle, and a very small amount of recessions may not really give you too much effect. So these are broad limits, not necessarily, but remember, you just don't get confused with the incomitant strabismus we were talking about earlier. These are limits so that you don't have a post-op incomitance. You don't have a comitant strabismus converting to incomitance and patient starts talking about diplopia and side gazes. Those amounts of resection procedures or supramaximal were reserved for incomitant strabismus. So you have an incomitance which you can try to reduce or improve, but there was incompetence, so you can't do much about it. You can handle that with a higher amount of surgery. So I'll just go through the recession. As I mentioned, I use a fornix incision. So this is the lateral rectus. Inferolaterally, a fornix incision was made in the conjunctiva and the tenons. The muscle hook hooked an untoothed muscle hook, or the Jemiesons hooked the muscle, followed by the greens. Now we have prolapsed this lateral rectus out of that opening we had made in the inferior part of the inferior fornix. We cut a small opening above the muscle and we pass the lens hook. We identify that we have the whole muscle and we have not split the fiber, so you look for the upper pole. After that, you start your dissection. Again, variable amount depending upon how much you want to recess. One should definitely recess beyond the amount you are going to recess or resect, so that there are no residual tenons. You'll pass your sutures. From here on, it's just like whatever way you were doing it for whether a fornix or a limbal. If you use one double-armed single suture, vicral 6/0 vicral, you can put one knot in the middle and then two side passes, deep bites, so that you have the posterior part of the fibers also. Again, similarly, one above. You disinsert the muscle. When you are making your mark, remember to be perpendicular to the cornea and not hold it from where you are putting the mark. So you don't want to distort the place from where you are marking. You are holding it a little away. After that, you pass your sutures, of course, very carefully, just making sure that you have the bump and you're not going full thickness through the sclera. This is in fact the area where the muscle is thinner, and if you've used two separate vicals, you're going to have two knots, one superior, one inferior, and if you of course have used one single suture, then you'll have one knot in the middle. So that's how you need to make sure that your points are equal and separate. There is no tenons or any tissue that is caught in the knot, which will contract and cause retraction. And of course, you can suture the stump, especially for the lateral rectus, because that is visible. Sometimes the patient finds that unsightly, and the fornix incision can be sutured very conveniently with an 8-toe vicral. We go on to the strengthening procedure. So you have a graded resection procedure, graded resections and plications. So these are the two recti strengthening procedures. Again, for resections, you have maximum and minimum. Minimum amount, again, you may not be very effective, but for maximum, it's important. If you go very far back, you start incorporating myofibrils in your suture, in your plication or resection, and that also weakens the muscle a little. Again, supramaximal surgeries for incomitance, we are using a longer than these amounts, but for conventional comitant strabismus, these are kind of limits I would stick to, and therefore if you have a larger angle, you may have to do 3 muscles or do a muscle transplant procedure. So this is a resection procedure I'll be showing you. Again, and an inferotemporal fornix incision. You reach the clear sclera, hook with the Jemiesons, follow that up with the greens, make sure that you have the whole muscle. You can do a pole test that you put the pole right up to the limbus. You make sure that you have the whole muscle. You open a small opening, identify that you have the whole muscle in your hook, and then you do your dissection again to the amount you need. Definitely in resections, you need to go beyond the place from where you're going to pass your sutures. You can see the inferior oblique. You need to be careful in your dissections. You don't want to damage or cut the inferior oblique there. So again, you measure, you remember, you flatten the muscle and don't allow too much of a fold over the muscle. Otherwise, you're going to resect more than what you had planned for. So for resections, we conventionally use 2 double-armed sutures. So we have a single vicryl we've cut into 2, so, and we've attached an RD needle to both sides. So 2 double-armed sutures. You can kind of cautery those vessels anterior to where you're going to cut, so that you don't have bleeding. You cut it just anterior. You leave enough stump. And again, for the stump, you cut it as flush as possible. You're not passing your sutures through your stump, but at the base of the stump through the sclera. Otherwise, it may just cheese wire through, and you may have a recurrence or a slipped or a stretched scar or slipped muscle. So again, 2 6/0 vicryls, superior and inferior. So we have 2 sutures pulling the muscle anteriorly, so that you have again 2 knots. And that ensures that because the muscle is on a stretch post-operatively, you don't have the scar stretching or the muscle slipping posteriorly. Again, you can just close the vicryl with an 8/0 suture. We go on to plication. I have shifted virtually completely to plications instead of resections. It's cleaner, neater, less painful for both the surgeon and the patient. So the approach is going to be the same, so just at the cost of kind of repeating the same, this is a medial rectus plication that we are going to do following a lateral rectus recession. So for a resect or a recess plicate procedure, you reach the sclera, you make a pocket in the intermuscular septum, you hook the medial rectus, Jemieson's followed by the Green's hook. This is the pole test. You ensure that your hook has reached the limbus, ensuring that you have all the fibers. You won't be splitting the muscle. You look at the upper pole, you make an opening in the upper pole, identify that you have the whole muscle, then you pass your Lensic through that. Again, like we are checking for that. We don't want to make a mistake, split the muscle and cause a lot of bleeding. So again, you pass your do your dissections as far back as you're going to pass your sutures. So here, I'm going to use 2 single-armed 6/0 vicryls. So 1 for the superior knot, 1 for the inferior knot. We use 2 passages through the muscles for the first round. Then we'll see this is the upper set of sutures. This is the lower set of sutures. You have to pass them well and truly through the bulk of the muscle. You don't want to have slipped or missed fibers. Theoretically, we say that it is a kind of vessel sparing, or you may not, spare the vessels, but really I would say that, you've tightened it so much, it may actually act like a tourniquet and not really give you enough vessel sparing. Now we've cleaned it just anterior to the insertion. So my suture is being passed just anterior to the insertion of the muscle. Both the sutures are now passed here. You can just see the insertion just posterior to that. Both the sutures are now passed. And we go back to the muscle. We go back to the muscle and pass our sutures again. So you have muscle, sclera, muscle attachment on both sides. Again, because in resection we had 2 loops above and 2 loops below, we have created that again so that there is good strength and there is not enough loosening. You can just push it back, or you just pull on the sutures and the extra part folds underneath the muscle. Normally, it will just fold underneath if you pull them, and therefore that unsightly knuckle we used to be worried about is no more there. You have to tightly make sure that your knot is tight, and it's because of the sclera is here, you want to make sure that it is tightly snug to the sclera. And again, so it looks almost like a resection procedure. The folded part has gone underneath. So that's what your plication procedure is. You'll close it just the way. I haven't made any significant changes in my nomograms for surgery, for resections when I move to plications, because I'm passing the suture just anterior to that. Resections are stronger. These are gross nomograms, just telling us how we can do our planning. You get 25% more effect if you operate one eye. You get about further 25% if you operate younger the children, infants, you get that much more. These are gross nomograms, which I tend to follow. There are a lot of books, different people have given different nomograms, and that's what they follow. So you can start with any, follow that up, and over time you can adjust slightly based on what you are doing. We'll just go on to inferior oblique. So we know the inferior oblique anatomy, just slight 2 millimeters above and about 10 millimeters posteriorly to the inferior margin of the lateral rectus. So we'll just see hooking of the inferior oblique, again, inferior temporal fornix. In fact, obliques are ideally used for, they are very effective and very simple. You just go on to this, see the white sclera, hook your lateral rectus, you just place a lens hook, you lift it, and that's here your inferior oblique sitting right there, waiting to greet you. You take an untoothed hook, muscle hook, you lift the muscle, and you start seeing the posterior white intermuscular septum. So that's the important thing. That will ensure that you have the whole muscle. You can lift and check that you have the whole muscle in your hook. And even through this, the posterior intermuscular septum, you can start seeing very clearly your muscle hooks. Just make an opening, and once you put your lens hook, again you can see clear white sclera there, and this is now your lateral rectus hooked again. You have your inferior oblique on your hook. You dissect the attachments posteriorly as well as with the lateral rectus. You disinsert your inferior oblique. It's not going to go anywhere. It's just going to sit there again waiting to greet you. You just take out everything and you just search here. You will find your inferior oblique. It doesn't go back because it has an anterior origin as well as the Lockwood's ligament. It doesn't let you go anywhere. Now you can comfortably have your assistant hold your muscle. You can pass sutures comfortably through this. I'll just show you the things. I'll just discuss first so we, just like recessions, we use graded recessions, we use graded weakening procedures for the inferior oblique. So depending upon the severity, so this is 6 and 6, the original Fink's method, giving us about an 8 millimeter of recession. You can do a Parkes 3 and 2, taking origin from the inferior rectus, giving you about a 10 millimeter recession. You can do a modified Elliott and Nankin, placing it right next to the inferior rectus, or an Elliott and Nankin that actually makes it a severely anterized muscle, or else you can use the inferior oblique and go nasal, making it an anterior nasal transposition, making the muscle act like a weak intortus. So I'll just show you how we measure for the Fink's and the Parkes. So here we have 6 millimeters and 6. So 6 millimeters, we take our insertion from the inferior insertion of the lateral rectus towards the inferior rectus and then perpendicular to the cornea. So this is the Fink's point. This is place where you're going to pass your anterior suture. This is an 8 millimeter recession of the inferior oblique. For the Parkes, so this is where we are going to place our suture. I'll just show you, in fact, the 3 and 2. So 3 millimeters from the inferior rectus lateral margin insertion. This is 3 millimeters posteriorly and 2 millimeters laterally. So this is the Parkes 10 millimeter recession. There is a little more effect because you are going to get a little bit of anterior, about a millimeter or so. So you can see 2 millimeters approximately and a little anterior position. So this is the Parkes point I mentioned. So there is a graded recession. You can use the inferior oblique to your advantage. In fact, make it like a small intorta. The superior oblique, absolutely wonderful muscle, extremely touchy, and can be angry if you do mess with it. But extremely effective. I'll just show you the most commonly performed surgery on the superior oblique to weaken it, correcting for an A pattern, especially with superior oblique overactions. For superior oblique weakening procedures, a lot of procedures are there. Like I mentioned, the posterior tenectomy of the superior oblique, the most commonly one done. I always prefer to approach the superior oblique from the temporal margin, and this is what a PTSO actually is. We've removed the posterior. So we'll time up. I'll just show you the last video. Superior temporal incision you make in the superior temporal fornix. You go right up to the clear white sclera. It's important to make all your approaches after you see the white sclera, otherwise you're going to have vessel bleeding and tearing up of tissue. So you open up the posterior intermuscular septum, you hook the superior rectus in this case now. After you hook the superior rectus, you put a lens hook posteriorly, and again you'll start seeing the posterior fibers. So these are, sorry for the initial decentration, but those are the superior oblique fibers that you are seeing. So these are the pearly white. When you are hooking these fibers, go posteriorly but rotate it a little nasally. You don't want to damage the vortex veins that are there. So there are two vortex veins at the insertion. You make sure that you have the whole muscle. You search nasally, you can see clear white sclera. Originally I used to take 2 millimeters and separate these fibers, but now I have observed that in most cases you see a curve. So these are horizontal, and then after 2 millimeters or so you can see a curve of the muscle going, tendon going. So that's where now I just arbitrarily make a separation about 2.5 millimeters, separating the anterior torsional fibers from the posterior vertical, although there is no real perfect demarcation, but that's how we'll remove. So you make sure that at least 8 millimeters or more of separation of the superior oblique fibers are done. So this is the separation that I'm doing. I cut the posterior fibers, and this is the remaining chunk of that superior oblique. It's a posterior tenectomy, so I have to remove all these posterior fibers and make sure that there is no risk of them going and sticking back onto the superior oblique. So this is that posterior window that you can see that we have created. I have removed, and these are the anterior fibers. So this is the oblique you can see going to the insertion and the cut posterior. So this is the posterior tenectomy of the superior oblique. Just to show you the outcomes, you can see the A pattern with the superior oblique bilateral, which gets corrected, and the superior oblique has been weakened enough to control the A. So thank you very much. Any questions we can just quickly take as we wind up the IC. Thank you everybody for coming.
Yes, please.
I have a small question. So in Duane's, when you do the horizontal with the vertical, and in SAXENA we are also doing the horizontal with the vertical. So as you said, that in Duane's we do the minimum horizontal if you're combining both. But in case of SAXENA, we are doing more of medial along with the vertical. That's a concept, correct, sir?
Yeah, absolutely. For Duane's, as I mentioned, we do less amount of, we have less deviations. The amount of deviations in iso-Duane's is much less than what you're going to see in 6 nerve palsies. That's in fact the classical differentiation of restrictive versus paralytic. So you do less amount of surgery, but in 6 nerves you can go supramaximal and do a lot larger medial rectus recessions.
Second question I have operated upon a small baby, not small baby, 3-year-old, intermittent XT. So I did bilateral LR recession. Immediate post-op was okay, but as I followed it up in 6 month time, it has come back to around 30, 35, it happens. My only concern is I have left out with 2 medial rectors. So should I go and put immediately, or we wait and do what I should do?
So that's why when IDS started, I said it is the toughest surgery to do. You're worried about overcorrections in the immediate post-op, and you're worried about recurrences in the late post-op. Yes, that is a problem a lot of times. Look if you have missed the obliques. That is one of the things. Of course, a 3-year-old child, it may be difficult, although with the Langs you are able to measure stereo acuity. But yes, a poor original stereo acuity may be the reason why he is deviating again. But I would say that you would have to go in back again and do your medial recti resections. Depending upon how much recessions you have done, you can further recess it, but then obviously you will start having abduction deficits, which can be a challenge.
Thank you, sir.
So thank you very much. I think we'll have the speakers for a photograph, and we'll call it a day. Thank you very much, everybody.
आपकी फोटो तो मिलेगी नहीं।